Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. All right, first things first, I have partnered with Frontline Optics to be a brand ambassador. I am rocking these sweet black Pomonas. These are actually the ones that I wear at work. And they sent me another pair, so thank you. Get yourself something, treat yourself, unbox yourself. It's owned by a paramedic, a first responder just like you. We support the first responder community. Use code OKMedic, OKMEDIC, at checkout for a 15% discount. And with that out of the way, let's get to the content. This is going to be a quick one, as usual, with a good deal of my episodes, as you know. I wasn't planning on doing anything with this topic anytime soon, but things come up at work, and when these things happen, that puts the proverbial Bunsen burner under my ass and causes me to grab my microphone and start brain dumping. And you all get to listen to it. Thank you for tuning in. I have gotten a few requests asking me to do an episode on being a BLS provider and how to be a good EMT. I started writing something a couple of months ago with some thoughts. I had all kinds of different thoughts I was trying to pull together, but I admittedly got some writer's block, and I wasn't really able to tie in all of the different things that were swirling around in my brain. And I just kind of abandoned the project and I focused on other things. If you're a dedicated podcast listener, you have heard me say many times on repeat the following statements. BLS before ALS. BLS saves lives. It's the BLS stuff, not the ALS stuff that is evidence-based, where pre-hospital medicine has the benefit. The basics will not fail you. And as I train all of my students, 85% of being a good paramedic is being a good EMT. Now, do I rip on EMTs? Yes. Please keep in mind that I rip on everyone, including myself. I am an equal opportunity asshole. I rip on administrators, I rip on physicians, nurses, paramedics, and one of my most favorite things to do in the world is to rip on the obnoxiously self-important flight community that I am indeed a part of. Nevertheless, there are plenty of hotel cuck chair aficionados who hear me offer my commentary and opinions when I'm talking about BLS, and they say that I'm just using my position as a paramedic and a podcaster and content creator to rip on EMTs and to build myself up in my own brain and to make myself feel better by coming down hard on the feeble, sad, vulnerable, huddled masses of innocent EMTs who are yearning to be free and who are just doing the best they can to make it through the day and to make ends meet. And that is not the case. I hold EMTs in very high regard, believe it or not. You've heard me say that I think the New Jersey dual medic response to everything ALS is stupid. Coming from Pennsylvania and Delaware, where one medic can legally tend to a patient, I have always said that on 90+% of my calls, I don't need another medic. Give me a good EMT worth his or her salt, and we can take on the world. Good EMTs are indispensable, and I hold them in very high regard. Yes, I am higher trained as the paramedic. When I'm on scene, I am the legally prescribed higher level of care. I am responsible for whatever happens to my patient. But I view EMTs as equals when it comes to importance of role and them being there when we respond to a call, which is why I get so pissed off when I see low standards and poor performance. I'm not going to go into the whole dissertation of how I think the National Registry has failed EMTs, in my opinion, by making the bar far too low for entry. I'm not going to talk about the woeful state of initial and continuing EMT education. I'm not going to talk about pay, low pay, poor organizational culture, poor leadership, staffing. There's good leadership out there. I'm not saying all of it's bad. And I'm just not going to talk about all that systemic, industrial, organizational type stuff here. Now, that's all a conversation that needs to be had. We've touched on it on the podcast, and I know other podcasters and blowhard content creators have discussed these issues at length. But that's not what I'm here to talk about. Today, what I'm here to talk about is This is directly to the EMTs who are out there doing the job, responding to calls, and I'm going to offer some advice and insight from my viewpoint as a paramedic and as somebody who was in your shoes. I was an EMT for 5 years before I became a paramedic. Granted, that was over 20 years ago. I started in 2002. But nevertheless, I can say that I was there for half a decade, slugging calls, moving bodies up and down the steps, being underappreciated, being underpaid, and working with ALS providers who did indeed teach me a ton, but sometimes could lay down a heavy hand and not be so nice about it. And as Cody so controversially said, that got the pro participation crowd trophy all spun up, chew some ass. They certainly could chew my ass out sometimes. Sometimes maybe they were a little over the top. Other times I'm sure it was justified. So here we go. What sparked this episode? I responded to a call recently. I'm not going to allude where. Before the EMTs in the community and the ones that I work with get all upset and they start talking and speculating, because that does happen where I work. I have heard before, hey, you were talking about me. And it's like, actually, no, I wasn't. Or I know which call you were talking about. Hey, you were right. I didn't say that out loud. But this did happen where I work, but I'm not going to tell you where because I don't want there to be any butt hurt. So I go to this call and you don't know where it was. It could have been at my ground job in PA where I work as a chase car medic in a 2-tiered system. It could have been at my flight job where we certainly respond to scenes and we end up being the first arriving ALS provider. And at our one base, sometimes we are the only ALS providers that respond because the local BLS squad does a pretty good job of recognizing, hey, this patient's really seriously injured. They need a trauma center. They know there's no close trauma center. So they don't wait for ground medics to arrive and they put us on alert and they haul ass 2 to 3 miles to our base. So I'm not going to go into the details of this particular call because I don't want to betray the trust and I don't think it's necessary to go into, and I don't want to punch down as the keyboard warriors say I do. But the basic skeleton story is that I, or we, see what I did there, keeping it ambiguous. The ALS crew makes patient contact. Now, this BLS crew had been with the patient for a few minutes, more than 5, which is plenty of time to start doing patient care. I/we make patient contact, and no care has been rendered. The patient was severely hypoxic, and I blew a gasket. Here are 2 EMTs responding with an ambulance that contains all of these tools, oxygen tanks, meds, that can very effectively and correct hypoxia, which you are indeed taught in EMT training to assess for and correct. That's not new or novel stuff for them to do. They have these tools, they have the training, they have the ability, and nothing was done to help the patient. I hear over and over again from BLS providers, I want to do more. We are not respected. We are not used to our full potential. And then I, as a paramedic, respond to calls over and over and over again. And I arrive to find that unfortunately, many times no care has been delivered to the patient. I told this particular crew after debriefing that call, you had the tools. Why on earth did you not use them? Other examples. All right. BLS, they have CPAP. CPAP is a life-saving tool. How many times have I responded to a call where BLS was on scene before me and the patient required CPAP? Many. I've hooked up many a CPAP, at least one a tour, and that's probably an underestimation. And this is no exaggeration for the sake of making a point. This is truly honest. Do you know how many times in recent memory I have arrived on a call, BLS has been there for a few minutes, and they have on their own put the severely dyspneic patient on CPAP? 1. BLS has the ability to administer a duoneb, regardless of whether the patient is already prescribed a beta agonist. I'm talking about in my area. I don't know every program in the country's protocol set, but they can do duonebs where I work. And they do. They carry nebs, and they can administer one neb treatment. Do you know how many times I have responded to a call where BLS is on scene? I find a patient dyspneic, wheezing, and they have administered a duoneb? One. And that EMT who was on the call is a medic in the military and he's almost done nursing school. That means I can say that when it comes to EMTs without any further training past the EMT level, administering neb treatments to wheezing dyspneic patients, I can say that I have seen it happen 0 times. I'm not saying that this is you. I don't want to get an email or a DM from somebody in Tennessee or California and say, hey, this is, you're slamming EMTs. We give duonebs all the time. I put a patient on CPAP this week and saved their life. I'm just telling you from my experience and from what I see. I'm not calling you or any particular person out. How many times has BLS requested ALS for chest pain? Countless. And look, it annoys me, but I get it. I go on tirades about the chest pain thing. And yes, I am aware that I am complaining and ranting, but I fault the DOT curriculum and the National Registry for training EMTs to just shut their brains off when they hear the words chest pain. You can certainly train them to discern what is suspicious for ACS versus what is less suspicious or concerning. Regardless, EMTs can give aspirin to anyone with chest pain, and they can assist the patient with their own nitroglycerin if that patient is prescribed nitroglycerin and is having chest pain. How many times in my recent memory have I responded to a call and an EMT has given one of these chest pain patients who is prescribed nitroglycerin a dose of their nitroglycerin for active chest pain? 0. Aspirin, very occasionally. I have seen it. I will give them that. It's still not a lot though. So my first piece of advice to EMTs is, you want to be a good EMT? You have the protocols, a whole vehicle, and a bag of tools. Use them. Guess what? Those things save lives. They reduce morbidity. They make the patient feel better. You can deep dive into PubMed. In pre-hospital care, exception being blood products, which an EMT can't do, that is an exception. It is BLS stuff, BLS procedures that do the bulk of the life-saving. And you have the tools, use them. Don't complain about not being appreciated and not feeling useful and not being used to your full potential when you are granted the authority via protocol, legislation, standing order medical direction, and you are provided the tools to carry out those protocols, and then you don't use them. I'm not a firefighter, but consider the following comparison. When I arrive on a call, BLS has been there for a few minutes and I find that nothing has been done and I have to be the one to initiate care. It is the same thing as an engine crew arriving at a working fire. There's people inside of the structure that's on fire and the crew stands around and waits for the battalion chief to show up and tell them what to do. Now, you sure as hell wouldn't do that on a fire call. Why should a critically ill person with a medical emergency, or even a moderately or mildly ill person having a medical emergency, be any different? Controversial statement here. If you're hesitant about employing things, the tools and procedures you are granted by your certifying or licensing bodies probably are not going to hurt the patient if you use them. If you give someone nitroglycerin who's having chest pain and it ends up being musculoskeletal or they end up having pneumonia, you're not going to hurt them. Even if you drop their blood pressure a little bit, the nitro's soon going to wear off and it's neither here nor there, usually. If you give a duoneb to someone who ends up not having bronchoconstriction as the etiology of their shortness of breath, it's not going to hurt them. If you put someone on CPAP who doesn't need it, you're probably not going to hurt them. Yes, there are side effects, there are negative effects, there's untoward effects, and you can, well, what if every scenario to death? But it's not like you're responding and giving IV lidocaine or you're synchronized cardioverting someone or performing a rapid sequence intubation. If you use a tool in your BLS protocols, there is only a minute, exceedingly small chance that you're going to cause any harm. And guess what? That's by design. They thought about this and they built that into protocols when deciding what BLS can and can't do. So EMTs, know your protocols, know your tools, know how to use your tools, know when to use your tools, and please use them. The next thing, BLS stands for basic life support, not basic lifting service. I have worked a bunch of places over the last 23 years. As I have said, it took me 15 years to finally find home. A commonality that I have seen in almost all places I have worked that is a two-tiered system is that I see EMTs that have an emphasis on getting the patient onto the stretcher and into the ambulance. We just wanted to get him out of the house and into the ambulance. Where in your protocol set does it say that the priority is to move the patient's physical body from where they lay and out to the ambulance? Nowhere. Do a freaking assessment. Initiate care, then worry about moving the patient. Look, I get it. My style, personally, I hate paramedics who set up camp on scene. For my opinion, for what it's worth, you don't have to agree with me. We can do almost all of this EMS treatment stuff on the way to the hospital. Especially where I work, the transport time is at least 45 minutes. Although even when I worked in the hood where the hospital was super close, I was still able to get a lot done in a short transport to the hospital with the minimum scene time. I appreciate getting the patient to the ambulance and efficiently out the door, ready to roll. But that's not the goal of pre-hospital medicine. The goal of pre-hospital medicine is to perform a patient assessment and initiate needed care at the point of illness or injury in an austere, non-hospital environment. Yeah, if the patient calls 911 for a sore throat for 5 days, they meet you at the door with the suitcase packed, by all means, let's keep moving. An object in motion stays in motion. Walk them out to the ambulance. But when the patient is having an acute, serious problem and or merits investigation to find out what's going on with them, take your time, do an assessment, initiate care. That is called assessment and stabilization, which you certainly learned in EMT school, and as we discussed, it is in your protocols to do so. Again, don't talk about expanding a BLS scope and feeling unappreciated when your contribution to the call is simply, I lift things up, I put them down. If that is the ultimate utility of BLS, which I don't think that it is at all, but if that is the ultimate utility that you think that's where you tap out and that's where your usefulness is, then I will use my brother who works in home construction to solve the EMS staffing issue. He will at 5 a.m. go to the Home Depot parking lot on Naaman's Road where all of the day laborers congregate waiting for some contractor to come pick them up and offer them a job for the day. He will pick up 2 and drop them off at your ambulance station. Here's a quick 2-minute tutorial on how to use the stretcher and stair chair. Don't worry about the stair chair. The medic will show you how to do that. And you're good to go. You want to be a good EMT. Don't just be a day laborer who picks things up and puts them down. And the final thing I will say is, for the love of Pete, please get a patient history. Ask questions. Another paramedic summated exactly what I think happens far too often. He said, the history I have been getting from EMTs seems to be just a recitation of the dispatch notes. And I've got to say, I've been seeing that a lot. Just the other day, I pull up to a call and I am told, chest pain. I gave the and got nothing. Thank you for that intense history gathering. Just so you know, you got the exact same history of present illness that the gas station clerk who called 911 for the patient did. On another podcast, I told about the time I got in the back of the ambulance on an intercept and I was told stroke. And then I was handed nursing home paperwork and told, oh, all the details are in there. And they told me that because they didn't ask for any details. And no, the details were not in the package of paperwork. You didn't even look at the fucking paperwork. This is just demographics and a 15-page list of meds and times that the patient is supposed to get Miralax. And you know what the excuse was? Well, we just wanted to get her out of there and into the ambulance. Thanks. Now I've got to call the nursing home and get transferred 4 times until I get a hold of someone with a semblance of a clue who is going to tell me what is going on with the patient, because you didn't ask and then you left the scene and rendezvoused with me, so I could not then go in and talk to somebody who knew what was going on. You know how EMS crews, and I'm guilty of this too, are the first to bitch about nursing home staff giving super scant reports and not knowing jack squat about their patients. Well, it's the same thing when an EMS crew obtains a shit history and they play human FedEx and they just put the patient on the stretcher and move them from one geographical location to another. Now, I should say that this isn't just BLS. This happens with ALS. Certainly, all of what I'm talking about here happens with ALS crews too. I'm just tailoring this to the EMTs. And again, this is my experience, and I just personally happen to see this more from the BLS in my particular roles out there responding to calls. And once again, I'm not using this as an opportunity to punch down and shit on BLS. I love BLS. I had a code this morning, and the BLS crew that was there was fantastic. They did all of the work. You really didn't even need me. You could have sent a robot that could have pushed epi every 3 to 5 minutes, and epi, which we know doesn't help people in cardiac arrest. And the robot could have used an AI algorithm to say, that looks like PEA on rhythm checks. It was the BLS's show. And it can, and it should be the BLS's show on many more calls. That's not a fantasy world wish. That's something that should actually be a thing. Because, and I know I'm going to get it. Oh, here's a lazy medic that doesn't want to do his job. That's not what I'm saying. I'm just saying I think that the BLS could run a lot more calls. It's something that should be a thing. It's good logistics. It's good utilization of resources. And it's going to make them better EMTs. That is why protocols and system designs actually allow EMTs to do a decent bit if you know the protocols and you carry them out. So EMTs, know your protocols. You will be amazed at how much you can actually do, how much you can accomplish, and how you can make a difference for your patients and not just make them feel better, but maybe occasionally snatch someone from death's clutches. That's what I got. I will now wait for the torrent of poorly worded hate on the interwebs. Sayonara.